next hour is doing a bit of an overview of the AcutiyPlus productivity and workload system. And so, has anybody here, before I get started, can you tell me who you are and what unit you work on?
Oh, I'm Georgia Malone and I work ED and MedSurg.
ED and MedSurg.
I'm Colleen Rapp, discharge coordinator upstairs from MedSurg.
Okay.
I'm Mandy Urban, I work on the MedSurg floor.
Brooke Warm, and I'm ED MedSurg.
Okay.
Kate McEntee, I'm on MedSurg. Ashley Schwark, MedSurg.
So it sounds like not all of the staff go back and forth between MedSurg and ED.
Correct.
Just some of them? Okay. All right, so let me start with, before I start, has anyone worked with an Acuity system anyplace else? In any other,
I've seen Rochester work with them.
did you work at Rochester?
No, I shadowed quite a bit and saw the different levels constantly saying, oh, I need to go do my acuity and send it to the charge or whatever.
Okay,
Staffing. So I've seen it be done.
All right, so you've seen it be done. All right, so let's talk a little bit about the AcuityPlus system then. The system is meant to assess and measure nursing productivity. That's the whole point of it. And when you assess and measure nursing productivity, we do that to help you allocate your resources better. And you can use this information then to develop a budget or track different population trends. I don't know if on your med-surg unit, you have some higher need level patient, like a PCU, progressive care unit. Do you have progressive care patients there? In your med-surg unit?
What do you mean by progressive care?
Well, someone who needs a little bit more intense care, maybe on a monitor, maybe having some drips.
Yeah.
Okay, so what tracking patient population trends will allow you to do is to look at a subset of a population on your med-surg area. So you can look at the patients you define as progressive care versus the med-surg patients. And also model resource needs for new or revised services, meaning that if you were going to change the composition of your unit because you brought in different physicians and you're going to have different kinds of patients, we could actually use this information to model what you would need in staffing to handle a change on your unit. And then to benchmark with other healthcare facilities, and that includes the facilities within the Mayo system. So to do this, this is the first visit and I'm doing an overview, and then we'll do indicator education with the staff because Barb is going to do overall education at the end of this month, and then you will be going live with the system as of November 3rd. And then from that point in time, we will look at your data over periods of time and look at how that information is coming across on your units. What information are you getting? What does it mean? So that's what we're doing in the rest of the implementation. So the committee roles, if you've heard people talk about this, the project coordinator is Barb, and the steering committee is really made up or based on administrative nursing manager people who have budget responsibility, because the steering committee is going to be making decisions about productivity goals and things like that. And then the patient classification committee can be anybody, any of the staff that is going to help Barb monitor the information going into our software, as well as being a super user or someone that the staff can go to.
Just walk right up. It's very important. Let's have a seat.
So there are two approaches to staffing. One is a task-oriented one, where people would go around and follow nurses and find out what tasks they were doing, and then look at the time that it took to do a task. And based on the frequency and the time, you would get staffing recommendations. our system looks at what is the need of the patient. And because we look at the need of the patient, then we get workload index, and from workload index we get staffing recommendations. Now, the need of the patient is based on what does a patient need for care. So one of the examples I always use is if I have a heart attack here in Cannon Falls, what is my need for care? And my need for care isn't going to change if I have a heart attack here or in Rochester or New York or LA or any place else, right? My need for care, if I have a heart attack, is the same no matter where I'm at. Do you believe that? Yes, yes, because patients' needs are patients' needs, no matter where they are. What changes is how each organization mobilizes their resources to take care of patients. That's what's different from facility to facility. So our methodology is based on research, and we look at validity, transportability, and reliability. And these are the elements that we test. These are the validity elements that we test. And to make a long story short, a couple of things we test is this. If a nurse looks at our indicators, would she agree that the indicators identify patient care needs? If we give you staffing recommendations based on a patient type, as a nurse, does that make sense to you? If I say to you a type 3 patient gets X number of hours of care, does that make sense from a perspective, a clinical perspective of how you care for patients? And then the third piece is this tool transportable? Can we use this tool in Rochester, Cannon Falls, Red Wing, La Crosse, Eau Claire, Mankato, any of the places that Mayo has facilities? Can we use this tool across all hospitals within the same system? So these are the areas we tested the tool in: medical, surgical, and all of the subspecialties underneath it, critical care, all of those subspecialties, pediatrics, antepartum, NICU, nursery, oncology, bone marrow, orthopedic, rehab, burn ICU, skilled nursing facility, neurology, neurosurgery, telemetry, and intermediate care. Now, if anybody has any questions, please feel free to raise your hand and interrupt me at any time. So the workload measurement and staffing recommendations come from two steps. The first is patient classification. That is using the indicators. From that we get census and acuity. And then the second step is taking this workload index and translating it into staffing recommendations. And that is a customization piece. Everybody uses the same set of indicators, but the customization piece is geared towards each organization. So, patient classification is a process in which critical indicators are used to objectively differentiate patients into categories. Now, I'm going to say that again because I think this is sometimes difficult for staff, that the indicators are meant to differentiate patients. They're not meant to mark the same set of indicators on every single patient. If you mark the same indicator on every single patient, what does that tell you about your patient population? Come on, you're nurses. What does that tell you? You marked an indicator for every single patient. What does that tell you?
That they need whatever we mark, like vital signs. Some get them once a shift, some get them every 4 hours.
No, but if you mark the vital signs every 4 hours on every one of your patients.
Someone wasn't looking at what they were doing.
Well, if you're doing, if you're marking an indicator on every single patient, it tells you nothing about the population. It tells you that they're all alike in this particular piece. So, for example, we used to have an indicator called daily weights. Well, it got to a point where everybody had some kind of a daily weight. And that when that indicator was no longer a differentiating one, we got rid of it. So if indicators are being used on the majority of your population, they are no longer differentiating, and we get rid of them. So what we're looking at are a small subset of indicators that will help you differentiate patients. If we did this based on what you did for a patient, you'd have a list of 200 indicators. This is not based on what you're doing. This is based on the need of the patient, and those needs will, or using the indicators based on the needs, differentiate patients into one of 6 categories based on their need for care. Now, I will tell you, this is the hardest piece for staff to feel comfortable about. Because every time they look at the indicators, they say, I'm not getting credit for this, and I'm not getting credit for that, and I do this and I do that. And I know you do. And we take into account all of those other elements in different parts of this system. But the indicators are based on the need of the patient, and that's how they're to be used, to differentiate patients. Now, what that means is that you can have a patient that only has 1 or 2 or 3 indicators, and it's still enough to differentiate into a group based on their need for care. Okay, so the process of classification is a shift assessment for you at Cannon Falls is going to be a shift assessment. So you'll be classifying every 8 hours. And we'll use the indicators to differentiate patients every 8 hours. Now, one of the things we do have, and we were just talking in the back about it, is that we have the ability to give you acuity based on, as a byproduct of your documentation. We call that transparent classification. And that might be something that the Mayo system will go to down the road. So there are 2 types of classification. One is methodology and the other is activity. And I want to talk about the methodology first. The indicators describe the patient's need for care. And each indicator has a weight associated with it. Now the weight has nothing to do with time. The weight is a statistical weight based on the ability for that indicator to predict overall care requirements. So the higher the weight on the indicator, the more predictive it was in our research. Does that make sense to you? Maybe? Okay, good. The sum of the indicator weights places the patient into one of 6 categories. And again, we're differentiating patient based on care requirements. We don't look at how long an activity takes. That's another piece of the system. And indicators don't equal credit. Because one of the first things I always hear is, I'm not getting credit for this. And that's right. With these indicators, we're looking at the need of the patient, and then how we take these indicators and transform them into staffing recommendations is when we will take into account how you deliver care, which is what you're talking about. Now, the important piece in using these indicators is that you don't overuse them or underuse them, because either way can be problematic when you look at information. So these are the indicators. There's 24 of them. The indicators that are at the same color, it means they're mutually exclusive, so you only mark one of them. So you have 4 ADL indicators, 1 ADL rehabilitative, 2 ADL assistance, communication support, cognitive, 2 behavioral, 2 safety, isolation, 4 assessment indicators based on frequency. Vascular access site, Q1 hour, med prep greater than 20 minutes, wound management, we have 2 of those, healthcare management education, and one-to-one physiological intervention greater than 2 hours. So those are the 24 indicators that you'll have. These are the types that those indicators will differentiate patients into. So there are 6 types. Each type has a point range associated with it, has an acuity level, and it has nursing hours of care in a 24-hour period. Now what that means is that this is only direct nursing care hours. So it's only RN, LPN, and nursing assistant hours. This does not take into account the hours for a unit clerk or a manager. It's only the staff that provide direct care. Okay? Now, what the software does is it takes all of this information and it converts it to the equivalent of a type 2 patient. So that when we're looking at workload, each unit of workload is equal to a type 2 patient. Now I'm going to say that again. The software takes all of the different types and converts them to the equivalent of a type 2 patient. So, for example, instead of seeing one type 6 patient, the software says, oh, wait a minute, what this really is equivalent to, this one type 6 patient, is equivalent to 4.6 type 2 patients. Are you all with me? Okay, good. It's important that you understand that, because then when we start looking at workload on every one of your units, whether it's at Cannon Falls, Red Wing, Lake City, one unit of workload means the same thing on all your units. It means the one unit of workload is equivalent to a type 2 patient no matter where you are. And it's the same in your hospital, it's the same in Rochester, it's the same in Mankato, Arizona, and Florida. So workload means the same thing on all of the units. And because workload means the same thing on all the units, then administrators can look at workload and use that as a basis for staffing recommendations rather than just simply the census and the beds, right?
Oh, yeah.
Okay. Is everybody following me? Does anybody have any questions about that? Because it's important that you understand how the system works. Okay. So, this is a busy slide, and all I want you to know about this is that workload then is calculated by taking each number of patients in each type times the acuity, and in addition, we look at length of stay. So we look at workload if a patient stays 2 hours or 22 hours, it doesn't matter. That workload is added to your unit and it's part of what creates staffing recommendations. So when we get acuity, you'll get individual patient acuity. You'll be able to see that on the screen of the software. Once you classify a patient, you'll be able to see what the patient type is. And an individual patient acuity is the sum of the indicator reads. And then unit acuity is calculated. It takes the workload index, it divides it by the length of stay adjusted census. So we take the census times the acuity, we get workload, we take the workload divided by the census, it gives you acuity. And this workload is, when you see this 45, it means that the workload on this unit is equivalent to 45 type 2 patients. Okay? Length of stay adjusted census, because we acknowledge workload for any time the patient is on the unit, the software uses a length of stay adjusted census to do the calculations. And length of stay adjusted census is simply the number of patients that stay the equivalent of 24 hours. So if a patient stays on the unit for 12 hours, then the length of stay census for that patient is going to be displayed as 0.5, right? And if a patient stays 20 hours, then the census for that patient is going to be displayed as 0.83. And if a patient stays 24 hours, the census for that patient is 1, right? So you're never going to see a length of stay adjusted census that has total numbers in it, whole numbers. Because we're taking pieces of time based on the patient's length of stay. So, that's the methodology. Indicators differentiate patients, 1 of 6 care categories based on their need for care. The software converts all of the different types to the equivalent of a type 2 patient. Now, in addition to looking at the needs of the patient, We also know that there are activities on a unit that we don't pick up with the use of the indicators. And one of that has to do with the admission, discharge, transfer in, and transfer out process. So you get an admission, and you go and talk to the patient, and you fill out the admission forms, and you do that for every single patient that you get, right? And you use the same set of forms, and in addition to this process of admission, you need to care for the patient, right? Okay, so what we're going to do then is in the software, we're going to define minutes for each of these activities. And every time you have an admission, the system will add those minutes to the staffing recommendations for that day. Does that make sense to you? Okay, so in addition to these ADT times, you will also classify the patient. So you're going to be getting workload associated with this activity and with the care of the patient. Does that make sense? Okay, good. Plus 1 hour activities are activities that are infrequent and intermittent on a unit, but can impact the staffing of the unit. And because they're intermittent and infrequent, and they impact the staffing, these plus 1 hour activities must be performed by the unit-based staff, and they must be at least an hour in length. So a plus 1 hour activity that is infrequent and can impact the staffing on a unit is if you have a sitter. Do you use many sitters here? No?
Colors.
But do you ever have a patient that needs somebody just sitting with them? Okay, that's a sitter. Okay? Now, sitters are going to impact the staffing of the unit, right? Whether you take them from the staff that you have or you call somebody in to do that. So if you have a sitter that we're going to, and it comes from your staff, then we're going to identify the time the sitter is there. And then that time is going to be added to the staffing recommendations. So say you needed a sitter from 11 to 7 because you have a patient that has sundown syndrome, and somebody sits from 11 to 7, then we are going to add 8 hours of staffing recommendations to that time period to account for that plus 1 hour activity called sitter. In addition to that, you'll also classify the patient, right? And then other activities are workload related to non-registered unit patients or activities, and we will enter that as a volume by time. Now, one of the activities that you do, I think, because I know that they do it in other areas, is do you send somebody from your med-surg unit to the emergency room to help out? Okay, so for those particular time frames, if you go to the emergency room to help out for an hour, you are not on your unit to provide care to the patients that you have. So we are going to identify that as another activity, is when you leave your home, so to speak, and go to another unit and provide care, then we will put the time that you're gone into two other activities. And we will be able to see then the frequency of you leaving, the time it takes for you to be there, and how that workload impacts you over a 24-hour period. So we'll be able to look at that by hour of day. Does that make sense to you? Okay, good. Questions? These are the plus 1 hour activities, and I don't know that you'll use all of them, but you might. And then again, you might not. And I'll be going over the definitions, but you have 2 that are safety observation by an RN or a non-RN, off-unit accompanied by an RN or non-RN, patient family education by an RN, extensive blue management by an RN and a non-RN, coordination of care by an RN, 1-to-1 by an RN, 1-to-1 by a non-RN, and 2-to-1 by an RN. Those are bedside procedures. So these last three are procedures performed at the bedside that require one nurse for at least an hour. Okay, so the workload measurement then becomes a combination of the classification workload plus your admission discharge workload plus the off-unit activity and sitter workload plus any non-specific or other activities such as going to the ED to help. All of that is the overall workload for the unit. Questions? Did we miss anything? Okay, good. Okay. If we're looking at acuity to define how many hours of care a patient needs, complexity of care looks at who should provide the care. Now, complexity of care is a score that you get when you classify a patient. Complexity of care uses the same set of indicators as acuity does. So when you classify a patient using that set of indicators, you'll get two scores. One is acuity, one is complexity. Acuity looks at how many hours of care a patient needs. Complexity looks at the skill of the worker. And because of that, the weights are different for acuity versus complexity. And I'll give you an easy example to think about. One is in acuity, if you have safety management issues and you have to do an observation every 2 hours on a patient, that has a certain score associated with it because it requires time to do that, right? In complexity, the score for that is very low because it does not take an RN to do that activity. Does that make sense to you? So in complexity, the indicators that are weighed higher, have a higher weight associated with them, are those that must be performed or require a professional care provider. And this is, complexity has 5 types, acuity has 6. Okay, so the results of the classification are acuity, complexity, and workload. And once you begin using the software and the methodology, we need to make sure that the data goes in is accurate, because if you have garbage in, you're going to have garbage out. So we have system control activities for census, acuity, and staffing. And for census, there are a set of guidelines. Now, all of the Mayo facilities use the same set of guidelines about how to classify patients, what time frame you're going to use, how to classify admissions and transfers in, because you're going to do that all 24-hour period, and when discharges should be completed. So the guidelines for classification will be provided for you during the education session that you're doing in October. Daily census classification is important. It's important that everybody gets classified on every shift, all admissions and transfers in. Now, what will help you is that the screen for our software is color-coded. So if you have a new admission or transfer in, that patient will have a red bar across them. That means that the patient has never been classified on that unit. If a patient has a yellow color associated with it, it means that that patient hasn't been classified on that shift. And once you classify all your patients, then at 3 o'clock, their names all turn yellow again, telling you that you need to classify them for the next shift. So that visual cue can be helpful as you look at classifying patients. And the other thing we can use is an unclassified patient detail report that can be generated for the previous day. And then I always look at the actual declassified hours just to make sure that over time people are classifying everybody. Now, are you going to classify everybody all of the time? Probably not. But if we have a variance between the number of patients that came in and the number that are classified, and it's less than 2% or on average 1 patient per day, that's considered acceptable. And the reason for that is, our software starts at 7 a.m. and it goes until 7 a.m. If you get an admission at 5 in the morning, by the time you go to classify that, it may be after 7 a.m. the next day. So that time frame from 5 to 7, that patient may not be classified. Acuity. When we look at acuity, and Barb will be working with staff that are going to be monitoring the classifications. Now, all monitoring is the ability to help staff understand how to use the indicators appropriately. That's the only point of doing it, so that staff are not overusing the indicators or underusing indicators. So the monitors will classify patients based on their documentation and discussion with the nurse, and then we'll compare it with how the nurse classified to how the monitor classified. And the goal is 90% patient type agreement. So if I mark an indicator, if I mark ADL complete and you mark ADL partial, and I'm the monitor, then basically you have underclassified because I'm saying that this patient required a higher level of ADL. Does that make sense to you? Okay. Staffing is important because many of the reports require staffing to generate. So Barb will be working with all of the sites to make sure that actual staffing goes in every single day. So that's step 1. That whole piece is step 1. Methodology, activities, ADT. Step 2 is the staffing recommendations. And so for step 2, these are customization pieces that are decided upon by the steering committee. And one is target hours per workload index, which is simply a productivity goal. And I'll talk a little bit more about that. Shift distribution and skill mix based on acuity and complexity. So what we did talk about is acuity, complexity, and workload. We haven't talked about hours per workload index. So let me just give you an example. Hours per workload index is a productivity goal which says I want to multiply this workload by a goal of 6 hours for every unit of workload. That's all. That's what a productivity goal means. So every day, no matter what the workload is, if it's higher than this or lower than this, we're going to multiply this workload times this target. Because based on how we deliver care, we feel that we need to deliver 6 hours of care for every unit of workload. And that's what we're doing. So if we multiply the workload times those hours, we'll get 283 direct care hours in a 24-hour period. And if we divide it by 8-hour shifts, that is equivalent to 35.4 8-hour bodies in a 24-hour period. That's what we're saying this unit needed. Now, when you're looking at targets, targets are built based on a number of pieces of information. One is philosophy of patient care delivery, how you deliver care. Or you have primary nursing, do you do team concept? Financial constraints. We don't create targets that are greater than your budgets. What is the quality of care you're looking for? What are the outcomes you're looking for? Physician practices. We all know that physicians can impact the practice in any facility. And skill mix. What is your mix of RN versus non-RN? Minimum staffing levels. And this is important because minimums mean what you need to staff your unit if you only had one patient. That's what minimums mean. And then these pieces up here, leadership, roles and responsibilities, staff experience and stability. Basically what that is saying is this. If you have an experienced leader and experienced staff, they are always more productive than a new leader and brand new staff. And then unit size and layout, and I went upstairs with Barb to look at your layout. Beautiful up there, isn't it? I really like it. And then workload fluctuation and support services, which to me, when I was upstairs, looks like you have a lot of support services, you know, like for housekeeping and dietary and things like that. So workload fluctuation is something we look at during an implementation, and that is workload generally will fluctuate 10%. But on some units and some facilities, you'll see a higher movement of workload. And so we'll see how your workload fluctuates in your organization. So activities included in the target are the direct nursing care, your indirect nursing care, charting, reporting, administrative, personal education of less than 2 hours. So if your manager wants to give you a brief in-service for 30 minutes, that is also going to be in the target. Personal non-productive, which is your breaks and lunches and dinners, and then any patient support activities that the staff provide. Transportation, unit management, housekeeping, dietary. So if the target gives us overall hours in a 24-hour period, gives you a bucket of hours, then the next step is how do we divide that bucket on days, evenings, and nights? And so in the software, we'll put in shift distribution goals by patient type so that we can look at how many of these hours then should be distributed on days, evenings, and nights. And then on a day shift, then we look at, okay, if I've got a bucket of hours for days, how do I divide these hours between RN and non-RN? And that's the skill distribution, and in the software we do that by patient type as well. So that on a report, based on these productivity goals of target and shift and skill distribution, you will see the system, the software, recommend staff by shift and by skill based on your workload. Are you all with me? Okay, good. Okay, now, if I were to look at these units, and we didn't look at this column, we just looked at census and acuity. As you looked at them, would you say those units are more alike or they're more different? If all you were looking at was census and acuity, what would you think? If we were just looking at the acuity numbers and the census numbers, they look different. But what we're going to be looking at is workload. And you can see these workload numbers, like for ICU, the workload is 26.9, and for Mother Baby, the workload is 26. So let me ask you, if the workload is the same, should the staffing recommendations be the same?
Not necessarily.
Why not?
Well, because one patient could require a lot more care than 4 others.
That's true. But if we're creating workload from census times acuity, and workload means the same thing on every unit, which is the equivalent of a type 2 patient. If the workload is the same, should the staffing recommendations be the same?
So if the workload is the census and the acuity multiplied whatever,
Sorry.
then it should be the same.
Yes.
Because, yeah,
Yes.
if it's taking into consideration all the patient care.
Absolutely. So theoretically, we could use the same productivity goal for every single unit, and have the staffing recommendations be based on the workload. And what that is more of a quality assurance issue. It's saying that we're providing 6 hours of care for every unit of workload, no matter where the patient is, right? Now, the hours are not the issue between ICU and mother-baby. Those can be the same. What is different on an ICU unit versus mother-baby unit? May not be the total hours that are different. What's different on those units? And yes, and what does that mean? How does that relate complexity of care?
It takes more nursing hours for one patient.
Perfect. So the hours may be the same or similar if the workload is the same or similar. What's different on an ICU unit is the percent of skill mix, right? So that the total hours may not be the issue. What is the issue is how do you divide those hours by days, evenings, and nights, and by what percentage of skill mix do you have in an ICU versus mother-baby. Okay, so activity staffing hours, you have ADT plus 1 hour and other hours for other activities. So for example, on an ICU, if we said an admission, transfer in, discharge, transfer out, if we put these minutes of care for each of these activities, and this is what occurs in an ICU, then this is what the system will add as far as hours of staffing hours recommended. So based on this ADT, this ICU, we will add 2.75 hours for the ADT activity. And they have a nurse going off the unit 3 times, a nurse going off the unit for 2.5 hours, coordination of care, one at the bedside. Total recommended hours for plus 1 hour activities is 8.5. So we take these ADT hours, activity hours, and based on that, the software will add 11.25 hours to the staffing recommendations for this activity, which is 1 8-hour equivalent, right? Right? Okay. So the overall staffing recommendations, instead of 283, they're now 294, or 36.8 8-hour equivalents. Now, if census times acuity equals workload, and workload times the target gives you staffing recommendations, then if we take these staffing recommendations and divide it by the target, which is what the software does, you don't have to do this, this would be the workload associated with plus 1 hour activities and ADT. And then the software takes the classification workload, activity workload, and if we take the total workload divided by the census, it will give us total acuity. So the reports will give you class workload, overall workload, class acuity, overall acuity, and the staffing recommendations will always be based on the totals. Questions? Okay. A couple of other things I want to talk about just briefly. One is the outcomes module. The outcomes module is available for you to use. And what outcomes does is it looks at the relationship between outcomes and staffing. So for example, if one of your outcomes is patient falls, or medication management, or med errors, we can look at the volume of patient falls in relationship to the percentage of non-RN that you have on your unit, non-RN staff. The assignment module is kind of a neat little tool, and I always have staff utilize this during an implementation. But the assignment module will take all of your patients that you've classified, and it will balance your assignment based on workload. So what do you think happens if we balance an assignment based on workload? Is the workload of every patient the same? No. So what you might find is that a balanced assignment for one nurse might be 3 patients, and a balanced assignment for another would be 4 or 5, depending on the acuity and the workload of those patients. Now, I'm not telling you this because I want you to change how you do assignments, but I think it's helpful to look at this and to kind of play with it as we go through this implementation, to say, if I wanted a balanced assignment, this is what it would look like. Because a lot of times I hear in different facilities, my assignment is awful, the worst assignment, and maybe they do. But if we looked at balancing the assignment based on workload, instead of getting 4 patients, maybe that nurse would only get 2. Does that make sense? Okay. The other is, we have a tool called the Discharge and Transfer Out Management tool. And what it allows you to do is it allows you to create discharge criteria by unit to say, if this patient meets this criteria, maybe we should look at whether they're ready to go home or transfer to another facility. Now, some hospitals use this tool in their quality assurance. They have a discharge manager, they have a discharge group of nurses who go around and take a list of patients and talk to physicians and say, these are patients that look like they're ready to go home, what are your plans of their discharge? Well, this is the same kind of a tool, but it uses the acuity to identify the patients who might meet that criteria. And then once they've met the criteria, then you can also generate a report that will show you the date they met the criteria and the date they were discharged or transferred out. So it helps you look at utilization. It also can help you in times of, if you had a disaster and you had to define how many patients you could send home, that kind of tool could be helpful as well. And then the staffing forecaster. Now, this is a tool that is used a lot by the Mayo system, and you will also use this. And a staffing forecaster looks at what your unit looks like right now, and it allows you to identify changes in census. So it allows you to look at where your admissions and discharges are and transfers in. It will allow you to look at whether you're going to need +1 hour activities on the next shift. And then it gives you the forecast for staffing needs based on what you anticipate, but has not yet come to the unit. Does that make sense to you? Because our system is a live system, if you know you have 2 patients coming, we can't put that into your staffing recommendations based on classification because they haven't yet arrived on the unit. The staffing forecaster allows you to model what the staffing recommendations would be with these new patients and changes on your unit. I'm not going to go through these calculations a lot because actually you really need to see your data So, I talked about an unclassified patient detail report. This is what the report looks like. It would give you a list of names, start time, end time. These are the hours that were unclassified. It allows your manager to go back and determine why they weren't classified. Monitoring summary report. This report is generated after you've done monitoring. It gives you the number of patients to be monitored, number of classifications that were monitored. The recommended number of patients to be monitored is based on your budgeted census. So that comes from us. Number of classifications that have been monitored, number of classifications that are unique patients. So if I monitor Sally Smith on the day shift and monitor her on the evening shift, then that's 2 classifications of 1 unique patient. Number classified higher by the staff, number lower by the staff, number in agreement by type, and then percent patient type agreement. A daily a shift staffing report. You know, in some places that they don't have a lot of changes, or they have a nursing supervisor that wants to look at what has been scheduled and what is recommended. You can generate this report every shift, and it will tell you based on each of the units and their workload what is scheduled by skill and what is recommended. Now, sometimes nursing supervisors use this to move staff from one place to another, or they might use it as, okay, if this unit has this much staff that's recommended and it's different from scheduled, maybe I will put the first admission on this unit. Hospital summary report. This is a report that can be used by administration to look at all of the units. So we can look at all of the units in the river corridor from all of the hospitals, and we can look at census, workload, acuity, complexity, what the system would recommend in direct care providers, and how you're actually staffing. And then we can look at productivity by looking at hours per workload index and hours per patient day. This daily staffing report is a little bit busy, but it's kind of like the daily shift staffing report. And what it does do is if you're not having a lot of changes in admissions or transfers, then you can generate this report like for evenings, nights, and days the next day, and a 24-hour total, and it will give you staffing recommendations for the next shift based on what you have on your unit right then and there. The executive patient care summary, and I know this is a little hard to see, is like a dashboard report where it looks at census numbers, looks at staffing, budgeted, recommended, and actual, and the variances between recommended and actual. It looks at productivity of workload and hours per patient day. It'll give you the percent of actual RNs, and then it will give you reliability, patient type reliability. So this report can be run by day or by week or by month, and a manager then can look at their whole unit and how it operates. If you're doing it by month, is there some seasonal variations to your unit? Do you have seasonal variations here? To your patients? Do you have different patients in the winter than in the summer? Okay. Any questions? You've been awfully quiet. I don't know if that's good or bad.